Anisocoria. Difference between the size of the pupil. It is physiological in 20% of the population. Clinical types of anisocoria. Physiological, also named simple, essential, or central. Minimum anisocoria, mostly less than 0.4 mm. Both pupils react well to light. Normal dilation in dark. No dilation lag and equal dilatation of both pupils with topical cocaine. In isolated condition, no associated symptoms like ptosis, dilation lag, normal iris on slit lamp examination, and no exposure of pharmacological agents. Meiosis of one pupil, effect of local miotic drugs like parasympathetico-mimetic drugs, effect of systemic morphine, iridocyclitis, narrow, irregular, non-reacting pupil, Horner syndrome, head injury in case of pontine hemorrhage, senile rigid meiotic pupil due to effect of strong light, and during sleep, pupil is pinpoint. Mydriasis of one pupil, effect of topical sympathomimetic drugs like adrenaline phenylephrine, effect of parasympathetolytic drug like atropine, homotropin, tropicamide, and cyclopentolate. Sphincter damage, vertically oval, large immobile pupil, internal ophthalmoplegia, third nerve paralysis, belladonna poisoning. The evaluation of anisocoria. Patient with anisocoria, relevant history and eye examination, ocular trauma or surgery, check old photographs, use of topical medication, exposure to toxin and drugs, associated ocular and neurological symptoms and signs, ptosis, diplopia. Which pupil is abnormal? Examine pupil in light and dark. If anisocoria is equal in light and dark, and there is brisk reaction to light, then it is physiological anisocoria. If anisocoria is worse in dark, test with 10% cocaine. If both the pupils dilate, then it is physiological anisocoria. If small pupil does not dilate, then it is Horner syndrome. And further test with 0.5% aflaclonidine. If small pupil dilates, then it is Horner syndrome. If there is no changes in the size of the pupil, then it is physiological anisocoria. Anisocoria is worse in the light and is associated with ptosis and ophthalmoplegia, then it is third nerve palsy. If there is isolated sluggish reaction to light near dissociation, use 0.1% pilocarpine. If large pupil constrict, then it is aditonic pupil. If large pupil does not constrict, use 1% pilocarpine. There is partial or no constriction, then it is pharmacological anisocoria. Tonic pupil. It is the damage to the ciliary ganglion or short ciliary nerves produces tonic pupil, which is characterized by the following. The affected pupil is larger, moderately dilated pupil, reaction to light is absent, near reflex is very slow and tonic, accommodative paresis, cholinergic supersensitivity of the denervated muscle, constrict with 0.1 to 5% pilocarpine, while normal pupil does not. Adistonic pupil, dilated pupil, poor light response, better near response, due to ciliary ganglion disease or short ciliary. Initially, paralysis sphincter pupillae and may paralyze ciliary muscle, causing failure of accommodation. Gradually, accommodation returns. More fibers from ciliary ganglion innervate near response than light response. Pupil sphincter response return more slowly and remain sluggish to light and more response to light near accommodation, usually unilateral in 80%. Healthy young women more than men and response tonically due to dilute pilocarpine 0.1 to 5% due to denervation hypersensitivity. The features, symptoms are differences in the size of the pupil, unilateral blurred vision and may be asymptomatic, critical signs, anisocoria, more in the light, slow pupillary constriction due to near response and slow redilation, iris sphincter sector palsy, segmental pupil response, vermiform pupil response movement. Other characteristic, diminished deep tendon reflexes of the knee and ankle, Holmes-Addy syndrome. Idiopathic right tonic pupil. The right pupil is mid-position and larger than the left. poorly react to light but reactive during near viewing the examiner's thumb. The patient complained of blurry vision in the right eye while attempting to read, consisting with accommodative paresis. After instillation of 0.1 to 5% pilocarpine eye drops at 0 and 5 minutes into both conjunctiva, 30 minutes later the right pupil constricted while the left did not. Third nerve palsy. The clinical features are diplopia, deviation of eyes, limitation of movements, drooping of eyelids, diminution of vision for near, facial and facial asymmetry. Pupil is mid-dilated and light, consensual and near reflexes are affected. And there is characteristic down and out position of the eyeball. Pupil involving left third nerve palsy due to head trauma. The ptotic left eyelid is being evaluated, revealing the exotropic and hypotropic left eye and dilated left pupil. The left pupil is fixed. It does not react to direct light. Notice the intact right pupil constrict to light shown in the left eye consensual response. The Horner syndrome, sympathetic paresis. The Horner syndrome, also known as oculosympathetic paresis, is a combination of symptoms that arise when a group of nerves known as the sympathetic trunk is damaged, as shown in the figure. The causes of Horner syndrome: the central, preganglionic and postganglionic. In the first-order neurons, there is brainstem disease due to tumor vascular demyelination, sphingomyelia, lateral medullary syndrome, spinal cord tumor, and diabetic autonomic neuropathy. In second-order neurons could be due to Pancoast tumor, carotid and aortic aneurysm and dissection, and neck lesions due to glands, trauma or post-surgical. Third nerve neurons, there is cluster headache, neuralgia, ICS dissection, neuropharyngeal tumor, otitis media, and cavernous sinus mass. The Horner syndrome is characterized by ptosis, inferior ptosis, meiosis, pupillary reaction is normal. There is dilation lag, facial anhidrosis, and heterochromia iridis. Left Horner syndrome due to cervical spinal cord trauma. In room light, the left pupil is meiotic and there is left upper lid ptosis. The left iris is lighter in color than the right, acquired heterochromia. After instillation of 4% cocaine into the both conjunctiva at 0 and 1 minutes, then checking 45 minutes later, the normal right dilated and the left did not, and the difference in the sizes was greater than 1 mm, confirming oculosympathetic paresis on the left.